Thanks everybody for coming. Just a reminder to everybody, I'm going to post this lecture on YouTube, so keep all of your comments anonymous and rated G, especially you, Cammie, because I know you've got a problem with that. Okay, so I hope everyone had a good time. This is Halloween at my house. This is my brother John. Here's me. What do you think of me with a mullet? I think I look handsome, like an 80s, handsome in like an 80s way, you know. And here's the gang. And here's some of the loot down here. So we're going to go over an illustrative case today. I think that's the best way to learn. And this is not him, but it looks a lot like him actually. So it's an 88-year-old man with a chief complaint of headaches and right-sided neck pain. And his chief complaint was headaches, frontal headaches, but also pain in the back of the neck. When he lays down, it feels better. In the last 6 months, he's had dizzy spells, and he's needed a walker for the last 2 to 3 years to walk. He is 88, so it's reasonable, I think, for his multiple conditions like arthritic conditions, etc. But he feels like he's not walking well. He has high blood pressure, atrial fibrillation. He had a pacemaker in 2011. Both hips have been replaced. He's a widower. He's 5 feet 9 inches, 165 pounds. And so does anybody have any questions about this case? So the patient's 88 years old, and he has headaches and neck pain. Anyone want to know about the history? Okay, he's brought in by his son. He lives alone, right? He lives alone. So on exam, he's a thin man, 5 feet 9 inches, 165 pounds, and he walks with a slow, wide base gait, bent forwards, and ataxic. So when we say he has headaches, his headache was more frontal in the front of his head, but I thought this cartoon's good just so that when we explain headaches, we know exactly where they are. So here's the frontal area. Here's the parietal area. These are the names of the bones of the skull. Temporal area and the occipital area. And Aaron, so far in your vast experience, what's the most common area for headaches that you've seen?
Frontal.
Mostly frontal? Okay. Anybody else? What do you think? Did everybody agree most headaches are frontal? Like in the front here? No? Okay. So he also had ataxia, or difficulty walking. So basically ataxia can mean almost anything, but just the ambulation is not normal. So this is a cartoon of a spastic gait, and this is one of scissoring gait where the adductors of the hip are tight and spastic, and the people, when they basically cross their legs when they walk. Now you don't see many adults walking like this just because adults just quit walking. They just can't do it, either mentally or physically. They don't have the strength or the stamina to do it. But children do. So has anyone worked with cerebral palsy children? Have you guys? So you've seen a lot of this. The children, they have scissoring gait and spastic gait. But as they get older, they don't do that. You very rarely see people, they just stop walking. So he did not have a spastic gait or a scissoring gait. He walked more like a Parkinson's gait, actually, very slow, wide-based, bent forward, and he was a bit ataxia. So this is actually, I found this on the internet. This is a great way to explain ataxia. To keep her balance, the child with ataxia walks bent forwards with wide feet apart, and she takes irregular steps like a sailor on a rough sea or someone who's drunk. And you can see the steps here, how the child will walk. So adults also get ataxia too. So I think elderly people who have cervical stenosis, they walk like this. They don't walk with scissoring gait. Usually they walk with this wide-based, bent forward gait. Would you agree with that, Aaron? That's how he walked? Mm-hmm. Yeah. So this is also, in cases with cervical stenosis, severe cervical stenosis, it can be a double whammy because you can't walk well. So what's the next thing that happens? Anybody guess? Huh? You fall down, right? So if you fall down, what happens? Let's say you don't hit your head. This is not a trick question. Like what? You could break your hip, right? That's the most common problem. But then if you hit your head, that's usually these patients die because they have cervical stenosis. They fall, hit their head, and they die. And that's why I think most people who fall, hit their head, that's how a lot of them, how they die. They fracture their spine, or they have severe cervical stenosis, and the spinal cord injury is high, and they just stop breathing, and then they die. The other thing that this man said, he had difficulty buttoning his buttons in his shirt. So the function of the hand isn't well. So it's usually it's a higher cervical problem when that's the case. And the other thing patients say, they drop objects, and usually you don't care if you drop an object, but the one that they care about is hot coffee, and a lot of people drink, like Amanda's drinking hot coffee. If you drop your hot coffee, Amanda, right? Yeah. If you drop your hot coffee, big problem, right? It's like, so that's the one thing that patients always tell you is, I dropped a cup of coffee and I'm worried, because it's hard to function if you can't hold hot objects. So I just put this slide in here. Is the Ranawat classification of neurological deficits for cervical myelopathy. It's either no deficit, either subjective weakness or diaesthesia, hyperflexia, objective weakness, long tract signs, and the inability to walk. So this man had a pacemaker. So the next step, what would you do if this man presents to the office, neck pain, can't walk, what's the next step?
Imaging.
Imaging. So what did you order?
CT, because you can't have an MRI with this pacemaker.
Yeah, he can't have an MRI because of his pacemaker. And why do you guys think you can't have an MRI with the pacemaker? Can anybody guess? Why not?
It'll shut down the pacemaker.
Yeah, I think it affects the function of the pacemaker itself. And also, what is the pacemaker? So you got this thing that makes the electrical impulse that makes the heartbeat. And then you got these things are made out of what? Like metal? And they go where? In the heart. So there's the other fear is that it can like pull on the wires within the heart and cause the damage. But apparently the newer ones now are MRI compatible, but the MRIs no one will do an MRI with a pacemaker. Okay, so we had to do a CT myelogram. So has anyone here done a CT myelogram? David? No? So see, a CT myelogram is basically another way to image the spine. It's a CAT scan, CT scan, but on the CAT scan you can only see bones because it just lights up calcium. To see the nerves, what you can do is insert dye where the cerebrospinal fluid is present. The dye floats all the way around the spine because the CSF circulates, and you insert the omnipaque dye where the CSF is present. It circulates all over, and then you can see the spinal cord and nerves because it's contrast. Does that kind of make sense? And it's usually inserted at L4, L5, only because when the patient lays flat, flexes the spine forwards, that opens up the spinal canal. And L4, L5 is below the level of the conus or the spinal cord, so it's a relatively safe puncture. You insert the dye, and then you have the patient lay in an Xray machine and also a CAT scan. So here's this patient's, this is his myelograms, this is the needle, and the radiologist inserted into L4, L5, and this, he pushed the dye and he got an Xray, floor Xray, just to confirm he's within the spinal canal. And what do you see right away in this guy, actually, that he has in the lumbar spine? He's got stenosis, right? He's got a little bit hourglass sign, and you can see where his facets are compressing into his thecal sac. But that's not what we send him. We send him for a cervical spine. So this is just a normal CT myelogram. I want to show you what's normal. This is a cervical spine. Here's the spinal cord. And on either side of the spinal cord, you see there's CSF. And the CSF is bright. And everywhere where the CSF is not present, which is the spinal cord and nerves, is black because it doesn't light up on the CAT scan. So the dye shows the spinal canal and the nerves. The nice thing about the CT myelogram is that the resolution is very high. So the number of little pixels, like your television, who has here a high definition TV? Once you go high definition, you cannot go back, right? It's so incredible. So you always want to have the best possible definition, highest number of pixels per picture so that you can see things clearly. And CT myelogram is better than an MRI scan. But the negative thing is you have a needle into your spine, which is can cause problems. But the Omnipaque dye has gotten a lot better now. It's water-based. It used to not be water-based, and people would get these horrible headaches. So people who are like older than had a myelogram 20, 30 years ago, they used to be very painful procedures, but now they're not at all. People almost never get problems. Okay, so here's our guy. So luckily, due to the magic of the internet and saving images, I could pull up his old CAT scan from 2008. So here he is in 2008, and here he is in 2013. So, Aaron, what do you see? What bone is this?
C1.
So C1's here. C1's the first one, the ring, and this is C2, the one underneath it.
Right.
And look at these erosive erosions into the C2 dens. Doug, good morning. So let me bring Doug up to speed. This man is 88 years old. He presented with neck pain and ataxia. And he has a pacemaker, so we got a CT myelogram. So that's where we are. This is a CT myelogram. So 88 years old, ataxia, pacemaker, so we got a CT myelogram. So here's the spinal cord in this patient. And Amanda, what do you think? Should the spinal cord have this curve to it? Like that? Can you have any guesses what this thing is? Is this normal? She said, I read her lips. She said no. She said she's got a cold. Yeah. So the answer is no. And the spinal cord should be straight. And he has this pressure on his spinal cord from Pannus. So he's got pressure on his spinal cord at the very top of his cervical spine, where the skull meets C1, C2, deforming the spinal cord and also compressing the spinal cord. So this is his problem, and it's a very, very serious problem, as you guys can imagine. So and it also has progressed. You see how in 2008, 5 years ago to now, see how the C2 has been destroyed now. So this is a destructive process of Pannus, which is from usually rheumatoid arthritis. And the Pannus, we're going to go over what Pannus is and what Synovitis is and how it's affected. But the Pannus is a destructive process within the synovium that can invade bones and destroy bones. And can you see how C2 is being destroyed? Also, the other interesting thing is look at the skull C1, C2 articulation in 2008 versus now. C2 is now almost up against the skull here, and C1 is nearly almost destroyed as well. Look how I'll show you a normal. There's not much left of C1 and C2. So basically, this man, where the skull meets C1 and C2, is being destroyed by this inflammatory process, which is like rheumatoid arthritis. Although this man does not have the migratory, he doesn't have a diagnosis of rheumatoid arthritis, and he doesn't have the migratory articular abnormalities that make a diagnosis. But he's like rheumatoid arthritis. Okay, so let's go over Pannus. So this is not the patient, but I pulled this out, found it on the internet, where everything is found in the world, of Pannus and what it looks like on MRI. So the Pannus forms from the transverse atlantal ligament between C2 and there's synovium there. And the synovium can proliferate, and we're going to go over this, proliferate and enlarge. And the problem is, if it happens in the knee, it's not too big of a deal. Or Doug, what happens when, actually Doug's here, so Doug, what happens when you get synovitis in the knee? Like, what happens?
It gets big and swollen and painful.
So the synovium gets big, swollen, painful, and also the cartilage gets destroyed, right? And people lose the cartilage within the joint, and they need joint replacements usually. And when you do the disease process occurs on the synovium, so when you do a rheumatoid arthritis knee, you always remove the synovium, right?
Synovectomy.
You do a synovectomy. So you remove all the synovium because it's part of the disease process. And if you do that, patients do very well. So here's an inflamed synovium, and just so in the knee, the lining of the joint has synovium, and the synovium is just one layer thick, isn't it? It's just one layer thick, and it secretes synovial fluid. But it also has some kind of immune function, and it goes crazy with rheumatoid arthritis. So the question is, what's Pannus? So this man's problem is basically he's got Pannus at C2 compressing his spinal cord. But you may say, like I can look at Erin's right now, she's thinking, what's Pannus? I don't know what Pannus is, right? What's Pannus? So I'm just going to read this. I'm sorry I'm reading a slide, but I have to read it. So recent theories on the pathogenesis of rheumatoid arthritis suggest that synovial cells of these patients chronically express an antigen that triggers the production of rheumatoid factor, an immunoglobulin molecule, directed against other autologous immunoglobulins. An inflammatory response is initiated, involving immune complex formation, activating the complement cascade, I don't know what that is, and infiltration of polymorpholeukocytes. The fibroblasts proliferate, inflammatory cells produce granulation tissues known as rheumatoid pannus within the synovium. And the pannus produces proteolytic enzymes capable of destroying adjacent cartilage, ligament, tendons, and bones. And that's what happened in this guy C2. So the pannus produced proteolytic enzymes and is destroying the bones at the base of his skull in the C1, C2. And this destructive synovitis, which this guy has, results in ligamentous laxity and bony erosion, which causes cervical instability and subluxation. So that's exactly what this guy has. So this is, now we're going to go to the videotape. So we're going to copy. Everybody be patient with me.
You all know what this is. This is a person who has severe arthritis. You could see deviations of the joints into directions that they normally don't go in. You can also see radiologically, if you look at the bones of these joints, there is significant erosion and irregularities in the joint area. Also, grossly, you could see that the joints have a thickened amount of soft tissue surrounding them as well as all the other cardinal features of inflammation like heat, redness, swelling, and pain. In addition, if you were to look at some of the actual synovium surrounding these joint spaces, you would see that it is not only proliferated, but it was inflamed. This is rheumatoid arthritis. In rheumatoid arthritis, which is an autoimmune disease in which the body attacks its own synovium, the primary portion of the joint which is involved with the disease process is the synovium. As you know, synovial joints have bone involved in them, articular cartilage, underlying bone, joint spaces, perhaps tendons, and synovium. And in rheumatoid arthritis, a synovitis is the primary pathologic process. Here is some synovium. Not only is it proliferated to the point where it's forming somewhat of a papillary configuration, but you can also see extensive hemorrhage within it, as well as infiltrates of chronic inflammatory cells, as well as lymphoid follicles as well. With time, this can become more fibrotic, and in the acute phases, it can also be very necrotic as well. Here is the proliferated synovial soft tissue. Here is the lining of synovial cells, which of course every synovial space as well as bursa must have. Here is some fibrous tissue within the synovium. With time, this fibrous tissue can become increased. And here are areas of inflammation as well as lymphoid infiltrates within the soft tissues of the synovium as well. This is classical for rheumatoid arthritis, or if you would prefer, rheumatoid synovitis, because that's the primary focus of inflammation in rheumatoid arthritis. Thank you very much.
Okay, that was another YouTube video from Washington, D.C. So if you guys, there's some great histology online on YouTube now. And this was not present like a year or two ago. So if you guys are interested, you can do some more research. So I thought you guys would like that. That's synovitis. So any questions about synovium rheumatoid arthritis? The destruction of the skull, C1, C2. So it's a serious problem. So who knows what Atlas was? Who was Atlas? Somebody's got to know.
He's
Doug?
the guy in Rockefeller Center, isn't he?
Yes, there is a statue of Atlas
He's holding up the world.
in Rockefeller Center. It's made out of gold. It's holding up the
It's
world.
a gold plate, but gold leaf.
Yeah, gold leaf. So Atlas was a titan. So before there were gods, there were titans, the Greek gods, and the gods of Olympus, Greek gods, had a
Titan
war.
God? I thought a titan was a half god, a demigod.
He's a godlike. I don't know what they are. They're like godlike. They're god. They're immortal. So they had a battle.
They're in Nashville, aren't they?
Titans? They are now.
Tennessee Titans, yeah. And the gods won, and the king of the gods, Zeus, banished Atlas to carry the heavens on his shoulders. Not the earth, actually, the heavens. So the first pictorial representation of Atlas was in the year 200 AD. This is a statue made in Rome. And here he is holding the heavens, but not the earth. But because of this first pictorial representation of Atlas, from then on, everyone thought he held the earth up. Not true. It was the heavens. Okay, so why are we talking about this? The first cervical vertebra is called Atlas, and the reason why is because it holds the skull, which kind of looks like a round globe, which is from this actual statue. So there's a little history for you guys. So the first vertebral body, C1, is a ring, and it's called Atlas, and the second one is called dens, and they're special, very special vertebra because no other vertebra looks like them. So the vertebra, does anybody know why they're special? Like, why are they so unusual? Like, can anybody give a guess? Like, what's their special function? Or Doug, can you think? Like, why did either God or evolutionary design create these two vertebral bodies to be so special, have such a special form and function? I have my own theory. Because
Probably to get more mobility of the head,
yeah,
so you can turn and look and
yeah. So it gives them the
hear
majority.
the Titans coming.
Yeah, hear the Titans coming. So it gives the majority of our
C1 spins on the odontine process.
Yeah, C1 spins on C2, and it allows us to rotate. Right,
body.
the dens. So the dens is the C2, and C1 rotates around C2, and it gives us an incredible amount of rotation. So if you look like my dog this morning when I walk my dog, constantly rotating her head to look around.
Doesn't have an atlas. Huh?
They do. Dogs do. Almost all animals, the vertebrae look very similar. Yeah.
What about an owl? Can he go 180?
An owl goes.
Atlases, I think.
An owl goes 180. Yeah.
Because their eyeballs don't move.
An owl goes 180. Yeah, if you look at my dog goes on like a lot, like 130. I've watched her because I have an interest in these things. So animals, we've outlived our use, really, I think, because I don't think human beings are supposed to live much past 25, and that's why our necks don't work. Like when a patient asks me what kind of range of motion I'm going to have, I just show him my range of motion because I'm pretty limited because I'm starting to get old. So if you think about it, like we all lose our rotation. Okay, so anyway, that's I digress. So C1 and C2, and you get most of your rotation at that level. And just a couple important pathological, anatomical landmarks are the C1. So see how it looks like a ring? There's a ligament going across behind the dens called the transverse ligament of Atlas or transverse atlantal ligament. And this keeps C2 and C1 together. Without that, you can compress your spinal cord, and I'll show you that's called atlantoaxial instability. So again, C1 is an arch, and it has a little hole in the transverse process which is a foramen transversarium where the vertebral artery runs, and that goes into your brain. And again, the transverse ligament of C1. And C2 again has a dens, which is an extra projection superiorly. So basically, C1 does not have a body. So most vertebrae have a body. C1 does not have a body. And you're like, where's the body? The body was given to C2. So C2 has two bodies basically, that like a normal vertebra. And the C2 body goes up and goes to C1, and that allows all the motion. And there's actually cartilage in the front of C2 because that's a joint. And joints have synovium, and this whole area has synovium, and that's why you get the synovitis at C1, C2. So again, the dens is within the C1 vertebral body, and here's C1 and coronal, and you can see C2 is there, and it allows you the motion, mostly rotation. Now, the C1, C2 segment is right underneath the skull, so the skull sits on top of C1 and C2, and this is a normal alignment. The back of the foramen magnum, where the spinal cord exit, is called the opistheon, and the front is basion, and I'll tell you why we need to know this. So this is more anatomy. This is the back side. Here's C1, here's the arch of C1, here's C2, and here's the opistheon, the back of the foramen magnum. Again, there's more anatomy. Here's C2, here's C1, and you can see there's a joint and synovium back here. And normally it should be small like this, but like in our patient, he developed synovitis and it's pushing on his spinal cord, and it basically destroyed this whole area. Again, this is a cut, a coronal cut, and you can see the transverse ligament of the atlas, which basically makes C1, C2 stable, and I'll show you. This is more anatomy. The back from the skull, C1 and C2, these muscles are very important. So does anybody who can guess why these muscles are very important between the skull, C1 and C2? Anybody give a guess what they do? What's their function? They keep your head back, right? So they give you extension of your neck and keep your head looking straight, which is very important. Because if you can't, have you guys ever met someone who can't keep their head up? Serious problem. Right? Like you see in like muscle wasting diseases. I saw a patient who didn't have it. It's like a serious problem. They can't function. They can't see. They can't look forwards.
Or what about with babies when they're first born? They don't have strength.
Yeah, their heads are floppy. Yeah, yeah. That's more of like a neurological problem.
Oh,
but
no, it's just like.
It's a serious problem. Yeah, you got to be really careful.
Yeah.
And that's another reason why Aaron, I always say when we do cervical cases, we really don't want to remove the muscles off C2, because then post-op they may lose the ability to extend their head and their neck, and it's a serious problem. So we try to keep all these muscles intact. Okay, just more of that. So then, so this is a new question: is like, how much motion do you have at occiput C1, C2? Is it like 10% of the motion of your neck and head? Is it like 50%? Is it 90%? It's like 50 or 60%. So it's like it's at least half. And I'm going to prove it to you. You ready?
I was always taught that you have 50 degrees at 1, 50 degrees of flexion and extension at 1, and 50% of your rotation at C1, C2.
That's about right.
So if you're fusing these people, they're going to lose 50% of their,
At least half.
just at that one level.
Yeah, that's what I always told. It's like 50% of rotation and 50% of flexion. But why should you just listen to me? Why don't I prove it to you? You ready? So this is a patient of mine.
Tonight is today's date is.
Show you what her X-rays look like.
X-ray. She's now.
So this patient was fused from C3 to C7. So basically almost her entire neck was fused. And the reason why I made this video is like patients never believe me when I say most of your motion is going to be intact even though I'm going to fuse 4 levels in your spine. I don't do many of these surgeries, but I do sometimes. And they say, well, how can that be? And I tell them because most of your motion it comes from the occiput C1, C2. And they don't believe me. No one believes me. So what I did is I videotaped this patient who had this fusion, and this is her 1 month post-op, just to prove it to you how much motion you actually retain.
now it's been like, I know almost a good
Almost 2 months, yeah.
And the pain that I did have is never there. Now, if it should happen to turn around and run fast, it'll remind me.
She's 2 months post-op.
Other than that, I feel great.
Good. And how about, you did have some problems swallowing, I think.
When you think about it, swallowing and it don't go.
Sorry, guys, hold on.
For me was what helped me a lot. I had no more problems.
The motion that you currently have in your neck, because the surgery does cause some stiffness. So can you turn your neck all the way to the other side, as far as you can go? Okay, now hold still right there, okay? Hold still. So this is a side view, so you see she lacks maybe about 10 degrees that way. And now go the other direction. Okay. Here's the side view, so she lacks about 10 degrees in that direction. And make your chin touch your chest. Just look forwards towards me. There you go, chin to chest. And look all the way up. Okay, good. And raise your arms all the way to the ceiling. And out like that.
Okay, that's basically it. So that's pretty impressive, right? I mean, if you were to see it, you would not think she had a 4-level fusion. Okay. So I just proved it to you how much motion. So there are many lines that describe how the skull C1 and C2 should all be present. And I'm not going to get into that because it's just a lot of numbers, and to be honest with you, I can't remember any of them. But I just know C2 should be below the skull, and the canal should line up. The foramen magnum should line up to the spinal canal. If you can remember that, you can tell an abnormality. So what did I do is I thought to myself, what does normal look like? So how can you find a bunch of CAT scans of the cervical spine? When are they done?
In the ER.
What day?
Weekends probably.
Right. So I went on a Saturday night in Harford County and looked at all the radiology. I picked just one Saturday night, and I found 20 CAT scans. So you got all these people rolling through the ER, their neck hurts, and basically you get a CAT scan. And the reason why is that the CAT scans are extremely sensitive and specific these days. It's like 99.9% sensitive and specific. So they find fractures because the new way that they do CAT scans is it's three-dimensional. CAT scans are really, really good. So I found 6 CAT scans here that I wanted to show you and compare them to our guy. So here's a normal CAT scan. This guy was like 20 years old. He's probably like a car accident or hit his head. See how C1, C2 are way below the skull? And you see how C1's a nice round structure and C2 is normal? Now look at all these other people. Look at this guy. Who can guess what disease process this guy has? All of his bones are connected together. Look at that. What does he have? Ankylosing spondylitis. So this patient had ankylosing spondylitis. That's why they got a CAT scan on him. So these 3 up here, these patients are on the continuum of rheumatic disease process. This patient here, C1's totally fused on C2. This patient, C1 is going upwards and is migrating rostrally some. This patient has severe C1, C2 arthritis too, but it's pretty well aligned. So you can see our patient here, C1, C2 occiput are not totally destroyed, but pretty bad. And also he's got this compression of his spinal cord it looks like he's subluxating anteriorly a little bit too, if you can compare this to that. So it's like a confluence of problems. So what happens when the transverse atlantal ligament does not work? C1, C2 has instability. So normally you should look like this, and when you flex forwards, C1, C2 should be intact. But if it doesn't, if the transverse atlantal ligament is incompetent, the head can flex forward on the spine, and what happens is the spinal cord can get compressed between the two. Can you guys understand that? Because the spinal cord runs in the spinal canal. So here's a case of that, where the patient flexes forward, the spinal cord is in this little area here, and when he extends, it's in here. So basically, you kink your spinal cord at C1 if C1, C2, the transverse atlantal ligament doesn't work. Another type of instability is basilar and vagination. So that happens more with rheumatoid arthritis. Is the C2 can deform upwards and compress the spinal cord. And there are many other words for this: atlantoaxial impaction, superior migration of the odontoid, cranial settling, pseudobasilar invagination, vertical upward dislocation of the odontoid. So that's another way that C1, C2 can have a problem. That's not our problem. Our problem is proliferation of pannus at C2. So the question is, what do we do? Doug, since you're a surgeon, what do we do? Can we just let this guy stay as he is, just say you'll be all right?
No, he's probably getting compression, and he needs to be decompressed.
Yeah. So let's stop right there. So you can be decompressed. This is going to do it in steps. So you can decompress from the front. So you go in the front,
like a
transoral through the mouth, and take this whole thing out, which I've never either done or seen, but it's obviously very dangerous because you can get infected. You're going through the mouth, or you can decompress from the back. So I chose to decompress him from the back. So if you decompress somebody and remove bone, what can happen to the instability?
Make it worse.
It makes it even worse. So what do you have to do? You have to stabilize it and fuse it together. Okay. So per Doug, we're going to decompress posteriorly, and then we're going to fuse it too, so he doesn't get even more unstable and have even more problems. So you have to put fixation points superiorly and inferiorly. So superiorly, and we'll go over this why I chose a skull. I chose the skull, so this is part of my preoperative planning of how thick his skull is. You can see it's 6 millimeters here, 4 millimeters here, and at the level of the inion, at the very top of the skull, where you can get the largest screw, his was 14 millimeters. So that's a pretty good sized screw for a spine. It's very thick cortical bone, so you can get a very strong fixation in the skull. And where do you put the skull plate? Here's a foramen magnum. Here's an inferior nuchal line, superior nuchal line. So the very middle part of the skull, I'm going to go over this, is the thickest. So you can get a very strong screw in the very middle, but off the midline it's very thin. And the plate should sit between the inion and the foramen magnum right in the middle here, and the screw should be directly midline. So you may say, why is it thick in the midline? I have no idea, but it looks like a keel. You see how it looks like a keel here? So see how thick it is in the very middle? So you can put a very large, very strong screw in the very middle of the occiput there at the level of the inion. The other important thing is his cephalomedullary angle. This thing should be straight. It's 129 degrees, so normal is somewhere between 135 and 175. So the spinal cord should not have this angle, and that's just a measure of how deformed it is. So here's a normal guy. I picked this. This was a man I did a C5, C6 ACDF. This is what the spinal cord and medulla oblongata should look like. Pretty straight. See our guy? See how it's crooked? So that's from the pressure that he has on the top of his spinal cord. I showed you this distally. Where do you fix it? The best place for him is the lateral mass, and these are the lateral masses. I'll show you where you put a lateral mass screw. So here's our guy, and at its tightest, I measured 6.3 millimeters, which is, it should be, which should the spinal cord be? 10 millimeters, yeah. And this is a coronal section which shows he has a deformity, he has a scoliosis to his cervical spine too. So this is my preoperative planning, is where do I put my proximal fixation? I mean, can I avoid fixing the skull, which would be of benefit to him because then he would have a lot more flexion extension. But I don't think I can, because C1, C2 are basically destroyed. I mean, you can't even make out the anatomy, and I don't think they're going to be strong enough to hold the screw. Here's C1, C2. Here's the spinal cord. So the vertebral bodies at C1, C2 are basically destroyed. This is what C1 should look like. It should be a nice, perfect ring. And if in these cases you can put a screw in C1, but he doesn't have much of a C1 to do that. And then the question is, how much do I have to decompress? So I drew a line on the back of his spinal cord, and I kind of said, well, how much do I have to remove so the spinal cord can drape backwards? So I thought I had to remove all the way down to C5. And you can see if you took this way, this way, this way, this way, and this way, the spinal cord can drape backwards and give him plenty of room. So this thing will not compress the spinal cord. Does that make sense? See that? So if you take the back side off, the spinal cord can drape backwards and he'll have plenty of room. So that was the plan, is to remove C1, C2, C3, and C4 to give him plenty of room. You can see if you remove these bones, his spinal cord can drape backwards and have plenty of room.
Well, it looked like you could have gotten away with just like 1 and 2.
I thought about that. So let's try to see what happens if you just took this off.
Right.
You see how this may slightly tether it. And the other thing is, I have a problem with fixation anyway, so I felt I needed at least 3 screws. So it's not that much more work to do 2 or 3 more laminectomy levels. So I did consider that, but I felt I needed many screws in him, so that I'm afraid the screw will pull out because that's the product. So this is the plate that I used. This is a Depew Mountaineer plate, wasn't it? Mountaineer plate, and it has midline screws and the rods attached on the side. And I thought about maybe putting a C2 PAR screw, which goes basically, it's similar to a lateral mass screw. It just goes straight in and slightly upwards. It's actually the same thing. And this is the technique for inserting the lateral mass screws. So here's the lateral mass. You go basically in the midline and you point upwards and out. So it should look like that on the side view. And you want to avoid the vertebral, the vertebral artery, which is right here. So you see the screw goes lateral. If you go straight in, you'll hit the vertebral artery, which is a problem. You give the patient a stroke. So you always want to go lateral and upwards. If you go straight in, you'll go through the facet, which you kind of don't want to, although it's not a big deal if you're fusing that level. But in general, you want to go slightly upwards, so you avoid the facet, and slightly outwards, so you avoid the vertebral artery. Here's the vertebral artery. So you want to go out to avoid that, and you don't want to go straight in, you want to go slightly up to avoid the facet. So I held the patient with his skull with Gardner-Wells tongs. You can also use the 3-prong head holder. I feel the Gardner-Wells tongs is sufficient, although it's not as stable as the Mayfield head holder. It's just a lot easier to put on. And this holds the skull during the surgery. And the patient, it was done in a prone position, obviously because I have to go on the backside. And this is the exact table that I used, the Jackson table. And you can see how the Jackson table is free on the bottom, so the C-arm can go in and out so you can get a picture. The other critical part of the surgery is always elevate the head, so that there's 2 reasons. One, it bleeds less, because if you have a dependent extremity, you get venous engorgement and there's more bleeding. And also, there's less pressure on the eyes. So if you're, has anybody here hung upside down recently? What does it feel like? Do you remember when you're a kid? What's it feel like?
Pressure in your head.
You have a lot of pressure on your head and eyes. It feels horrible. So for an experiment, I put myself, I laid down on the Jackson table, and I put it all the way down to T-Berg, so my head was lower than my heart. I was very uncomfortable. My head, I was getting a headache. I could feel my eyes pounding. And you can imagine if you're asleep in that position for 3 hours, it's a serious problem. So that's why people get blind in the prone position if you're dependent. You can get blind from spine surgery. So that's another key component. So this is how you do a cervical laminectomy: is you cut troughs on either side of the lamina, and then you lift the lamina off and decompress. And I'll show you 2734. I'm going to show you guys a laminectomy. How do you do it? Sorry, guys. Aaron, can you remember 2734 for me?
Soft. See those little bleeding vessels? There's a leash of epidural venous vessels at this area lateral room. So that's Eric sucking, and I'm thin.
So first you make the troughs on either side of the lamina.
You don't try to reduce that listhesis.
Like this is the center, and these are on the left, and you make a trough up and down the lamina.
So you make a trough.
See how I'm drilling a trough on either side of the lamina? So I'm just going thin. Eric's sucking for me. I keep going thin. And I can see and feel when I'm through. And there's above and below, there's ligamentum flavum that keeps you safe from the dura, so you're not drilling right on the dura, because you don't want to do that, because then you get a spinal fluid leak. Although the AMA bit is not that sharp.
So you make a trough on either side to thin it down to remove it.
It can happen. I've had it. It's happened to me before. So I'm feeling, and I'm getting down to them all the way through.
And you thin it with the burr, then the final removal of the laminas with the kerosene
So I see I'm
punch.
sucking and I'm disconnecting, and you can see I'm pretty much through there, and I'm finishing it with a kerosene punch. I'm all the way through with a kerosene punch. So it kind of gives you an idea. And now that trough is done. See that? See I'm all the way through the whole way, and it's soft. And see those little bleeding vessels? There's a leash of epidural venous vessels at this area laterally. I don't know why. It's like, I guess God wanted to make spine surgery a little difficult for us, but He put them there. So we always get them and we pack them off, and it's sometimes they're very big, sometimes they're not so big. So you see we're kind of done. And this is Flow Seal that I'm inserting, which is a Baxter product, and it's an extremely effective anticoagulant. It's left from the scar, and if something, it's sometimes they're very big, sometimes they're not. A lobster tail, see that? And we're pulling it off indirectly.
This is how you take it off. You pull it off, and let me show you how you pull it off.
And it's an extremely effective anticoagulant.
So you lift the lamina, you put a clamp on it, and you lift the lamina up, and you tease off all the connections to the spinal cord. Remember the last case we did? Actually, this case, wasn't it? I couldn't remove it, and it had many, many adhesions to the spinal cord and dura.
Costs about $500 for 10 cc's. The hospital used to give us a lot of flack about it, but they don't anymore because we say we need it. So, you guys want to see more trough, or are you done with trough?
I want to see take away the.
Okay, lobster tail. Okay, Adam doesn't eat breakfast. He's hungry. He wants to do lobster tail. Okay, here's the lobster tail.
So I'm lifting it off.
It's been disconnected, but it's still attached to the ligament flavum, and this is the spinal cord here, and now it's peeling off like a lobster tail. See that? And we're pulling it off indirectly, and that's the safest way to do it. But there's always these attachments left from the scar, and if something's been scarred for a really long time, like for years, it develops scarring and ligamentous attachments to the dura. So now we're pulling off the lamina off the spinal cord and nerve roots. You see all these little attachments? So we have to do it really slowly and gently, and the whole time we're peeling off these epidural vessels and attachments to the dura itself. So we don't want to traumatize the spinal cord by manipulating it violently, and also we don't want these things to bleed. So we're doing it very slowly. This kind of gives you an idea of what it's like. See that little vein right there? We'll be done in a second. See all the attachments, and this is the spinal cord itself, but with a dura, and inside the dura spinal cord.
Now it's off.
So looks much better, doesn't it? Looks like it needed it. And the other thing is you can see it's really pulsating now, which is from the heart. So you have your own little you can the heart rate by just looking at the dura. So there's still some ligamentum flavum here and some.
So that's to show you how. So any questions about that? So that's the laminectomy. Here, this is what the instrumentation looks like. Lateral mass screws at 3, 4, and 5, and a plate at C1. So here's our patient. Screws in the skull and lateral mass screws at C3, C4, and C5. And he's had a laminectomy. This is a front view. Look, he has a total shoulder, and he's got implants in his teeth. And here's the lateral mass screw. See how it goes lateral and avoids the vertebral artery. This is a sagittal cut. Here are the screws in the skull, and you can see everything has been removed from the backside, and that allows the spinal cord to drape back. And can you make out the spinal cord here, or am I making that up? See it right there? See, it's got plenty of room now. I just want to make sure the skull has a keel in the middle, just like a keel of a ship, and here's our screw. It's well within the confines of the skull. And this is the best view of the spinal cord that I can get post-op. Here's the arch of, this is at C1. It's like it should be a ring, and see how the back of the ring has been removed? And this is the spinal cord itself. You see it? See how it's got plenty of room now, and it's draping backwards? And this is another view. You can see the spinal cord here. It's got plenty of room, and all this has been removed. This is immediately post-op. Again, here's another view. Posteriorly, all this has been removed, and now there's plenty of room for the spinal cord. And this shows you the lateral mass screws. And this is the patient pre-op. So I took a picture of him pre-op, and I took a picture of him post-op. And why do you guys think I did that? Why is it important to know what he looked like pre-op, post-op? What if you fuse him looking down? like flexed. He can't see the horizon when he walks or look people in the eye, which is a serious problem. And then what if you fuse his head too high? What can he not do? What?
He can't see the floor.
He can't see the floor. He can't tie his shoes. He can't see his like penis to urinate. These are all like serious problems. So you try to fuse the person straight. So that's why I got a picture of him pre-op. So in the OR, I was looking at him when I was setting up in the operating room table to make sure he looked good, and I did adjust him a little bit. So that's it. So any questions about posterior cervical laminectomy infusion? Stenosis? That's it?
You know, the old fixation, I think they used to put like rings or tunnels in the back of the spine.
Wires,
So
yeah.
Wire it down.
Yeah.
It was more for trauma, I guess, when people had
Yeah, C1, C2, occipital instability.
laminar wiring or something. I haven't seen this clip.
It works. The wires work, but
It's a lot though, and I think you had to, put them in a halo for a couple of months.
yeah, you have to protect the person also in a halo.
So how long do you immobilize this guy? You put him in a collar or something?
I put him in a Philadelphia collar, but these people take it off. I mean, it's like it does, and the Philadelphia collar does not protect you that much. But the other interesting point in this case, this patient did have some motion. I thought he would have no motion at all because the rest of his neck was so arthritic.
Right.
He did have some motion.
Really?
Yeah, he was okay with the restriction of the motion
Did
that he
you
had.
bone graft him at all?
I did. I took the iliac crest. I took a separate fascial incision iliac crest and I packed it with iliac crest just to make sure I gave him his best possible chance to fuse because of his age. Yeah.
How long did the ataxia take before you started seeing some result from decompression?
It may never come back.
So it could be a permanent.
It could be permanent, but in my experience, I'm not the most experienced person in the world, but I've probably done 20 of these cases maybe. They get better. They feel like they can walk. Like the other person I saw, a member of the elderly man that we did laminoplasty, he said he would trip over leaves all the time. He thought the leaves were causing him to trip. Now he says he's fine. He said he can walk through leaves now without tripping on leaves. Obviously the leaf was not causing the problem, but he didn't know what it was. He's a really nice guy. So I think it helps. Okay, that's it. Thanks everybody for coming.
Thank
you.
you.
Sure.